Hello, my name is Malik Abbas Dabu. Welcome to UPfront. On UPfront, we assemble the brightest people to answer the most difficult questions. It was touted as the greatest social intervention policy in Ghana's history. I am talking about the National Health Insurance Scheme. How is the scheme faring now? There are those who say the scheme itself is unhealthy. Is the scheme indebted? As scheme providers, those who provide services to the scheme, are they indebted to the tune of about 15 months? Has the government paid what it claims it has paid? When we come back from the break, I will introduce to you someone who has all the answers. Keep watching. You're welcome back. You are watching UPfront, and we are discussing NHIS today. President Nana Akufo-Addo recently said that his government has paid 1 billion out of the 1.2 billion Ghana cedis debt owed to the NHIS. This has been disputed. Is there substance to the president's claim? To answer all of these questions is the Chief Executive of the National Health Insurance Authority, Dr. Samuel Ano, who is my guest. Doc, you're welcome to UPfront.
Thank you so much.
When you were appointed last year and you were introduced to NHIS management, you said to them, and I quote, "I am here to champion the president's vision of revitalizing the NHIS," that's National Health Insurance Scheme. Are you succeeding in doing that?
There are two steps. The first step is that we have to identify why the NHIS was in the state that we found it at the beginning of last year. Heavily indebted, loss of confidence, service providers refusing even to see members holding NHIA cards, and members even refusing to renew their membership. That was the state we found it. So to revitalize it, we needed to try and bring it up to a point where some confidence will be restored to the National Health Insurance Authority. That we have done, and then we've gone on to tell the nation what we believe needs to be done to put it on a foundation that can be so solid that moving forward in the next 50, 100 years, we won't look back and worry again that our National Health Insurance Authority is on the verge of collapse again. So it's a two-front. The first front, I think we fairly succeeded in that. The second part is where we are, call it on the roadshow, discussing with the public, taking views on the 4 fundamental pillars that the management and the board of National Health Insurance Authority have brought forward to public discussion, that these 4 fundamental pillars, let us all debate and put it down. But once we put these 4 foundational pillars down, then we can say that the NHIA is on a solid foundation.
I'll come to those foundational grounds. But is your assessment of the state in which the NHIS was itself not faulty? And I ask this because I remember during the campaigns, the MPP consistently said that the NHIS was dying. And yet, there was evidence to show that MPP members who were contesting various elections at the parliamentary level were registering their constituents on the NHIS. There was evidence also to show that subscription had gone up substantially. How do you reconcile a claim that people are not renewing their cards, and you just made that point here, with the evidence that showed that there was an increase in subscription?
The woes of the National Health Insurance Authority started more or less from 2010, 2009 there. In the first 5, 6 years of the NHI operation, from about 2004, 2003 to 2009, 10 there, the scheme had enough funding. It had enough reserves. It had membership which were hovering probably around about 7, 8 million members. So in terms of numbers, in terms of the policy that we have put down to look after the members, it was adequate. And if I say the policy put down, I mean the 2.5% VAT and the 2.5% state was enough. Taking it from 2009-10 forward, saw an increment in the membership you are referring to. We picked to about 11.4, 11.5 membership around about 2015. Now, as soon as we went past 10 million, it was obvious that the membership that we had on the scheme, the funding arrangement which had been put in place was not enough to cope with the membership. So all the reserves the scheme had was wiped away. the scheme now started going into arrears, and the arrears kept growing until this controversial figure of 1.2 billion that the scheme owed service providers came about. Okay. So now if you have a scheme which you don't have an arrangement to pay for their cover, and you are piling on, certainly you're only helping to kill or put the final nails to the coffin of the scheme. We've just been lucky that the scheme wasn't ever declared bankrupt and sent to the gallows because Ghanaians have been patriotic. And I give thanks to our service providers. We owe them all these millions over a year, sometimes a year and a half or two. They didn't take the legal step to cause assets of NHIA to have been sold, which could have happened. So when we came in, we had to put in measures to try and talk to people which are not very essential, focus on people who were rendering the essential services, get some of their payments out of the way to restore the confidence. That we did very quickly. And we had to come out to say, it's not just piling on the numbers of membership, but also making sure that when you pile on the numbers, there'll be money to cater for them. So before we could even say that, from 2015 coming, although you say people were registering, the reality of the fact that the numbers were dropping, and by June 2017, when we did the numbers, it was dropping from 11.5 to 11 to 10.5. We reached 9.8.
Really?
Membership. We had dropped that low. It was only when we restored confidence that we saw members coming to get the card again, renew their membership again, and then get the service providers, the hospitals, the clinics coming to renew their credentialing again. So yes, we got to a point where it was dying a natural death anyway, because the card had become valueless, more or less. You go to the clinic, they look at it, they say pay 100 cedis.
How did you restore this confidence?
This we did in the initial phase by making sure that we focus attention on the service providers who looked after patients. Remember, we have various types of service providers. So we had to focus on those who look after patients. And we had to have a meeting with those who deal with non-core service provision to tell them that their payment will have to wait until sometime 2018. We discussed, they understood us. So most of the funding that came in the whole of 2017 went out to our service providers who saw patients. So that restored confidence in the service providers and also restored confidence in the members, because now they were seeing they were not asked to pay all the exorbitant fees that has characterized the scheme in the past. So that was all restored the confidence initially. And then we had to delve in to see how did we end up in this situation. And that was when we came with the 4 foundational pillars. Let us put these 4 foundational pillars in place. And once we, in consultation with the people of Ghana, were able to do this, then we don't have to look back again. We're not fixing the scheme for the next 5, 6, 8 years. We're fixing the scheme for the next 50 or 100 years. And that's what we're looking at.
What are those foundational pillars that you talk about?
We realized that the funding formula, which is the 2.5% VAT and the 2.5% Senate contribution that has been put aside to look after the health of this nation, was inadequate. Because we must remember, health is an international commodity. If you treat somebody with pneumonia in Ghana, the cost of it is the same like treating that same person with pneumonia in the US, UK, Ivory Coast, South Africa, or wherever you treat pneumonia. It costs you roughly the same amount of money. So in that respect, it's an international commodity. And internationally, we've said that to provide maybe basic primary health care across board for your members, you need about $86 per person per year. I say you want to provide slightly more than basic primary health care, maybe simplify the mathematics, make it $100 per person per year. Comparatively,
that's 450 Ghana cedis.
450 Ghana cedis per person per year. Some of our neighbors are doing probably 1,000. Europe is doing maybe $4,000 per person per year. The US tops with about $10,000 per person per year. We are at about $30 or $35 per person per year. So in terms of purchasing an international commodity, we are saying that from the start, we have to sort out the financial model. We have to find ways of coming up a little bit, even if we reach $60 per person per year or $70, then we are more coming into the market properly. That's the first thing.
And public sector workers are up in arms against you for one of the proposals you are making to deal with this, because you are proposing that they should expand the contribution from Senate, and public sector workers say no.
On the contrary, we had a tour of the whole country. We met organized labor, we met journalists of your kind, we met civil society people. On the contrary, majority of the people agree that they need to provide a bit for their own health. Remember, it's our health. It's not the government's health or somebody in abstract terms health. It's our own health. The major problem organized labor, the public had, was how efficiently are we looking after the little that we have. We understand we can't go to the market to buy plantain, which will know cost 10 cedis, and we'll go to the market for 5 cedis and say, sell us a plantain which costs 10 cedis for 5 cedis. That we understand. We also read. We know the international norms. But even the $30 per person or per capita that you have, how efficiently are we looking after it? How transparent is NHIA? How accountable is NHIA? These are the vibes we are picking from the ground. If we can be assured that the NHIA is accountable, transparent, we do not have a problem to contribute to our own health, because we also love ourselves and we love the health of our children and our family members. So that was the message we picked from the ground. Not that civil society, organized labor and workers were totally against contributing towards their own health. That was not the impression we got.
Let's do that. So you've dealt with one of the 4 pillars.
Yes.
What are the other 3?
The second one is, that is what it delved us into a lot of the controversy around, where people say that, well, I've been paid up to March. Somebody say I've received November 2017. Somebody say, oh, but I've only received up to June. Somebody said even my 2016 claim has not been paid. Now, the scheme receives about 30 million claims, more than that, per year. Now, imagine trying to process all these over 30 million claims manually. It's such a crazy exercise. I can't foresee how we've gone all this far with such a system like that.
So why is it that the system that you yourself introduced to do electronic verification or electronic processing of claims, why is that not working? Why is it that I am told only about 10% of those 30 million claims that you talk about go through the e-processing?
Processing of the claims to move it from manual to electronic hasn't been radically addressed ever.
Why?
Difficult to answer. Attempts had been made, and as you rightly say, they're only doing probably just under 10%. Even the 10% is not fully electronic processed, because we hear some service providers come to say that they kept my 10% behind, they kept my 10% and want NHIA to pay back our 10% which they kept behind. It is because the system of electronic verification, even the 10% that we are doing, is not fully electronic. So because of that, and they know from research that at least you save about 15%. So they are saying that until we are able to verify electronically properly the claims you are receiving, let us hold back 10%. And when we have the capacity to verify electronically properly, then we see whether you owe us or we will owe you. So that is the saga. We haven't confronted the problem as we should. And that's why we put it on a national agenda, so that we can be watched, we can be marked, and check whether we're able to achieve that feat or not. But it's never been able to achieve.
Why? Why have you not confronted it as you ought to?
Since we came in, we have looked at it, but it's taking a bit of time because of some of the bottlenecks that me and you know.
It's been more than a year.
Bottlenecks in civil service, bottlenecks in procurement process, but we have to make sure we go through all the steps. First, to get people to accept that that is the way to go. It takes time for people to even to accept that. So we did a bit of politicization, talking to people, discussing with people, for people to accept that to try and handle or vet 30 million claims manually is impractical.
Is the NHIS particularly slow in adopting technology? I ask this because I remember when the NHIS introduced the biometric registration process, and the process was to issue people with biometric cards and to facilitate the process and do it quickly. It was pain and anguish for many, and there were times people would go and sleep in NHIS offices just to get registered.
Yes, for some strange reason, I think we've had difficulty in adopting some IT measures. Even as we talk now, when we went around the countryside, one of the major problems of our members was going to renew their membership or going to get a new card. They still go to sit in our offices for hours on end. Some say they go today, they say come tomorrow. So many frustrations. As we say today, we finish our piloting. Going to sit in our office either to renew your membership or get a new card will be a thing of the past. Something which can be done by a mobile phone application in the comfort of your home.
I heard this 2 years ago, in 2015, that this pain was going to be done with and people were going to be given their cards It's been 2-3 years down the line. We are still there, and we are still hearing the same assurances from you.
Well, from the records that we came to inherit, there has not been any previous even piloting of MoMA renewal of membership. It only commenced beginning of this year. All the work with the International Labour Organization started last year. The piloting started at Sojamai this year. So it is only this year from the records of National Health Insurance Authority that I know that positive efforts have been taken to take people away from the offices, to renew their membership, to engage new membership out of the comfort of their home. It's only starting beginning of this year.
So we have leg 2 of the 4 pillars,
yes,
which is how to process
the claims.
The claims.
Yes.
And then what?
Leg 3. Leg 3 is that what I've made it simple for people to understand as the internal police force of the National Health Insurance Authority. Because going out there, the major concern of public to contribute towards their health hasn't been the 5 cedis a month or 10 cedis a month that they will pay, but it's been more with how accountable, how are you dealing with people who try to steal from our coffers? How are you dealing with them? And my answer is that we're not dealing with them efficiently, because we have an internal police force system. If I say internal police force, I'm talking about internal audit, I'm talking about quality assurance, clinical audit departments. These departments are all very weak. And they are very weak because after years of they attempting to work very hard, they are being frustrated by the 4 foundation, which is the legal side. After they go through trying to look for evidence for maybe 3, 4, 5 years to bring a case, to compile a case against people who have defrauded the authority or the organization, they take this evidence to the police take it to the Attorney General to court, and you go through the usual process of adjourning cases. Anytime they adjourn a case, it costs the National Health Insurance Authority so much money in terms of transportation, hotels, per diems, witness payments and all that, because witnesses go, they have to be paid for the day, whether the case is called on or not. And if this drags on for 4, 5, 6, 7 years, it costs them so much that it demoralizes everybody, that they found that even to chase somebody who has stolen 10, 20,000 from you is not worth the effort. So that whole internal police force system is very weak. And we are looking at revitalizing, restructuring, and making them a bit more strong.
I still feel I am hearing a campaign promise. And forgive me. When the NHIS Act, when the National Health Insurance Act 2003, Act 650 was changed to Act 5852 in 2012, the things that it was set out to do was to remove bottlenecks, introduce transparency, reduce opportunities for corruption. Where are we? 2012 to date, it's been 6 years.
And that is why probably I'm glad we are subjecting all this to public debate. Because if you look at the Act 853, it still calls theft or anything you do against our health fund as crime. And you go to the law books about how crime is treated, it does not differentiate stealing a banana from stealing maybe 50,000 from the National Health Insurance Authority. You could either be jailed 250 penalty units, or you could be fined that amount, or you could be jailed set months of imprisonment, or both. The judge has the choice to fine you with no imprisonment at all. And he can fine you the 250,000 unit or 2,500 penalty units enshrined in the law is so small that by the time you're going through the process of prosecuting somebody, you end up being the loser. So the law really is not punitive. What we are calling for, and which comes to the 4th leg of the foundation, is to enshrine in the law that if you steal something to do with a health fund, whether as a service provider, whether as a worker within the authority, then the law prescribes that you have mandatory imprisonment, maybe 2 years, 5 years, mandatory imprisonment without an option of a fine. And then if you stole finance, money, then maybe you pay probably 10 times that or any amount. So we have recommended 10 times what you stole. We have recommended minimum 2 years imprisonment. It's all waiting to go through our health department, through parliament. But let the public add their voice to it. Let us all debate and follow the trail. The problem with national health insurance is that, as you rightly put it from the beginning, it is the biggest social intervention that this country have embarked on. But it looks like we put it out there and we all went to sleep. People do not want to know what is going on inside the scheme unless there's a scandal or there's a problem or somebody. People behave as if because it is free, if I go to the clinic and tell me your car doesn't cover this or your car doesn't cover that, I'll go and pay that, I just accept it and then I walk away. People do not criticize and say that it's my right, I have to have this, I have to have that. People say we are not transparent. Our financials are posted even on our website. Nobody will even bother to go and look at it and critique it. But now it's good, it's in the media. People know that this is the biggest thing we need to protect. Because as a nation, we can run. But until we strengthen the foundation and our legs to work properly, we cannot run. And our biggest investment to allow us to run and develop this country properly is invest in our human
Are you
culture.
contemplating reviewing the law?
Precisely.
Especially the new Act 852.
Yes, we're looking at strengthening the punitive part of it. The punitive part needs to be changed.
How soon do you intend to do this? Because it's been almost a year and a half.
Well, it is with our ministry. They are doing stakeholder engagement to let people be aware of what is coming. We keep talking about it also on the media for people to know what our thinking is and what is coming. From there, we expect it to move to Parliament. I believe the surveillance of how fast it goes rests in the bosom of the media. The more you ask us about it, the more you ask the media or the parliamentarians about it, the quicker we put it in place.
How rampant is stealing in the NHIA?
It's difficult to say because, as I said, the appetite to prosecute is gone away. The appetite to prosecute had gone away. We're trying to revamp it, but it should be backed by the necessary law. There have been a few cases.
But you can't sack people. If you just find them to have stolen money, you sack them.
Well, it is not as simple as that. We started internal audit trying to pursue some of the illegal activities going on in our offices. And you've heard media stories when we started a bit in Ashanti region and other regions. People were saying they were being prosecuted because of one reason or the other. But the facts are real. If monies are not accounted for, we need to go after the people. And then you go after the people, they see other people, they want to come and complain, they want to say it is unjust. But because the legal processes are also very slow, you can only prosecute or suspend. The person is suspended, he still receives his salary. And receives salary for 5-6 years waiting for the court cases to be adjudicated. But fortunately, we spoke to the Attorney General. They've given us the right to be able to train our own legal department, strengthen the legal department, and prosecute our own cases. That again has been achieved by this year. The training is yet to start. Once we go over that bridge, we know that we're not going to wait 5, 6, 7 years.
But that does not solve your problem, because if you still take the people to court, you still have to produce or adduce evidence that is tight enough to warrant a conviction, and the problems of delays and adjournments will still be there.
We believe if we are prosecuting our own cases, we'll be able to make a case for special court to fast track these things. Of course, it's got to go hand in hand with the legal change also, changes in the Act 852 to make it more punitive. So we are working on all fronts. And although we are in a hurry to put this out there, it's also because we want to be checkmate by it. We want to be monitored by it, so that if we go to bed, the public will say, what is happening to these things? What is happening to these foundational pillars?
Let's deal with the elephant in the room. How much the NHIA indebtedness have you paid?
This has been in the media for quite some time now. And when people talk to me, I say, yes, we talked about this the whole of 2017. And I believe that 2018, it shouldn't be engaging our focus. Let's focus on the things we started with, the foundational pillars. How do we make this scheme sustainable going forward? This 1.2 billion debt that we came to meet, by some of the measures that I discussed earlier on, we managed to pay most of the service outstanding bills due the service providers. 2 or 3 days ago, our president came out to say that we've done about $1 billion of it, which is correct. As at the end of it is correct.
Where is
it is correct? Well, I've heard people say that it's not possible. It's not possible, but it is possible. It is possible. We have focused almost entirely, most of the revenue coming to us, most of it is going to payment or service providers' fees. Most of it. Okay. But again, as I've said, I think as a nation, let's direct our energy towards making sure that the National Health Insurance Authority sits on a solid foundation.
Yes, that's true. But when the president makes a claim, it's important to cross-check that claim. How do you know that you have paid 1 billion out of 1.2?
Because we do the payment. We do the payment. And we know that for 2016, we almost cleared most of the arrears that we have there. Remember, we had a bit of 2016, a little bit from 2015. Because remember, one of the big things that I spoke about is this manual processing. Because the manual processing of the claims is so laborious, the onus is not on the service provider to try and submit all the claims that he has for us within a stipulated time. When we came beginning of last year, we were receiving claims even way back as 2014. Some people bring claims which have been sitting with them for 2015. They lump claims at the Central Processing Department or CPCs with claims even covering 2014, 2015, 2016. So even at the end of 2016, when you believe that this is it, this is the amount that we owe, that is not the case. So when we came in, we couldn't enforce the rule that submit all within 3 months because we were indebted to them so much. But about 3 months ago, we sent a circular across the country. If you bring any claim which is older than 3 months, we're not going to deal with it. So that gives us a very clean slate, and we are very certain about the claims outstanding and what we need to pay.
One of the minority chief whip, and I'm talking about Mohammed Mutaka Mubarak, who is the member of parliament for Asawasi in Ashanti region. He argues that if you go through the budget, 2017-2018 budget, there is no provision anywhere for payment of NHIS. How do you justify a claim that 1 billion has been paid?
Now, he was talking or referring to the allocation formula. Okay. Now, if you use the allocation formula, well, you need to have time to sit and discuss the mathematics of it. To begin with, they have what they call a funding gap, which I heard the term not being an accountant or within that profession when we went to defend our budget for the first time beginning of last year. Okay. Now, this funding gap was about 450 million. Then you had outstanding claims also in excess of about 800 million, probably about 600 million. Now, if you take the funding gap, you take the outstanding claims, you take claims also in areas for non-service provision areas, like people who are building our district offices, people who are doing painting, wiring, and other supplies which are non-core, all that amounted to the 1.2. Okay. So by the time you pay, if you look at the allocation formula, you might not really be able to judge that because this amount was paid, it includes everything, includes the funding gap. Like this year, for the first time in the past 5-6 years, we sent to Parliament a budget we did not have any funding gap at all. There was no funding gap in the budget or allocation formula we sent to them for approval. All that has been wiped off. So you have to add all that to the other payments to be able to come to the cumulative figure. And all the other arrears which are to come to us in the course of 2017, from 2015, sometime 2014. You've got to add all of them up. But you cannot just look at a snapshot of the allocation formula and say that this is it. And that is where I have my worry about.
You said that you have decided this year that any claims that is older than 3 months, you will not accept.
We will not accept it. We'll make it very clear because they always come with reasons why the claim in 2015 or 2016 was not submitted, this reason or that reason, and almost invariably it gets accepted and processed. But we are going to be very strict with that. And we hope that if we are able to put in the electronic processing, that 3 months deadline that they have would be drawn back probably a month or two, probably a month.
So how do you explain the situation where some of your service providers now say they are owed up to 15 months?
I heard that claim 2 days ago and I was surprised. And when I spoke to some journalists, I said, I want to hear a specific name. Somebody doesn't come and say that I'm the secretary or the president of this association, of this group of doctors, and we haven't been paid. Give me a name of a clinic. Give me a name of a hospital. Let me go into the system and come and tell the public why this is so or why that is so. To begin with, if the name is maybe a cheap compound, a maternity home, or what do you call? Yeah, let's take cheap compounds, maternity homes.
Or polyclinic.
Well, the polyclinics are a bit up, but some of the low third.
Okay.
We've been engaging the Ghana Health Service. The World Bank is collaborating because they are interested in maternal and child care. And we are moving their payment to Ghana Health Service. Okay. Now, they will collaborate the figures and everything and then pay. So our component that NHIA will pay will sift the money to the Ghana Health Service and then they do the payment. So if the complaint is from a cheap compound or a maternity home, then I will know probably how to deal with. If it is a clinic or a primary hospital or a secondary hospital, let me have the specific name and I will challenge it that there is no service provider.
The name I'm giving you is Joseph Tambil. Joseph Tambil is with the medical superintendent group. And he was the one who granted us, and I'm sure you would have heard him grant various media houses interviews in which he said that many of their service providers are owed up to 15 months.
Yes. Can he give us his own hospital? What is his hospital? And I can get them to cross-check within 10 minutes.
Beyond that also, the Ghana Health Insurance Service Providers Association has warned that we are heading towards cash and carry. You don't believe they have a case?
No, not at all. We're out of the woods now. We're out of the woods. But I'm also very anxious about we focusing on going forward, because if we don't focus on that, probably a year or two along the line, we'll be back. And then that threat will be vindicated. But I strongly believe that we will do something about it. We will do something about it, and we will not be in the woods.
So you are stating categorically that no service provider is owed 15 months?
Definitely. Claim. Definitely. I will stick my neck out and say they must bring the name of the clinic. When the clinic brings their name out, it means that they have no problem with pushing their details out in public. And we'll print out their payments publicly and everybody will see.
How many months would you say the NHIA owes?
Traditionally, if any clinic or service provider is owed about 6-7 months, it's seen as normal. Because for some time now, the service providers have had about 3 months to try and collate the patients they have seen and bring us their claims. Sometimes they make it 4 months. That's why we have to send a circular that anything beyond 3 months, we're not entertaining it. And then when we receive it also, we have 3 months to vet, deliberate upon it and see whether this is what we have to pay. So you have about 6, 7, 8 months, which is within the playing period. Now, this interval is too long, and you can only shorten it by electronic processing. Until we get there, this is what we have. So if I haven't paid anything in 2018, for instance, 4 months, it's no news at all. If I haven't paid maybe 2 months, 3 months of last year, again, it's no news. So people who have not been paid up to June 2017 or July 2017, then there's a problem that we need to investigate.
Are there any?
If there are some, what I tell people is, if you have not been paid, I am sitting here saying that we've paid up to that point. We have the funding to clear the debts. If you have not been paid, bring it to our attention. That is why if I could get one clinic and then I could look at it, or one hospital who says that I've not received money for a year, then I can go to the computer system and print out that this is what is happening to accounting. So if you're having trouble, let us know and we'll come to you.
We have to take a break at this point. When we come back, I will be asking Dr. Ano, is the NHIS politicized? Why so? And how is this affecting the functioning of the authority? You're watching Upfront. Keep watching. You're welcome back. You're watching Upfront. My guest is Dr. Samuel Ano. He's the Chief Executive of the National Health Insurance Authority. And we are talking the health of the institution which is supposed to take care of our health. Doc, before we went on the break, I was asking the question about politics.
Yes.
How much is the NHIA politicized?
Thank you. I think this question is being at the lips of most Ghanaians touring the country. People are concerned about politicization of the National Health Insurance.
Because our authority is politicized.
Yes, yes, there's no question about that. And everywhere we've gone to, people have expressed their concern about it. And it's an area.
Are you as concerned?
I am concerned also about that. I am also honestly concerned about that, because if we do not collectively as a nation try and depoliticize it a bit, we'll lose track of the fact that we are dealing with a fundamental social intervention program which has no color discrimination, had no political discrimination. When you are sick, the disease doesn't attack only MPP or NDC or CPP. It has no political barrier. So we should discuss NHIA dispassionately without giving us a political color.
And I know
so sometimes I get worried when it takes that tangent or politicizing it too much.
And I note you say two things. you say, if we do not depoliticize it a bit,
yes,
and then in just the last sentence you say we politicize this too much.
yes.
If you say if we do not depoliticize it a bit, there's a certain concession that a certain amount of politicization is permissible.
Because we are human. Humans have their own likes and their dislikes and the like. But to go all out to use the NHIA as a political football on the open field is where I have my concern. Because even in the laws that we have enacted, Act 852, the Public Financial Management Act, and some of the laws governing the authority, I think as a nation, we should look at it dispassionately. Because one of the things that organized labor told me, for instance, they are saying that if we are to contribute our 5 cedis or 2 cedis or 10 cedis a month towards this authorization, this authority, then we want to see it a bit depoliticized. We want to have a greater say in the way its finances are managed. We want to see a little bit of transparency. Now, we're also concerned about, on several sides, they say they are concerned about where even a levy, which is supposed to be dedicated to the National Health Insurance Authority, still goes through a consolidated fund. And it has to be taken out of the consolidated fund, approved for payment, before it gets to the insurance fund. Now, it depends on who does the approval, who does the reconciliation in the consolidated fund. And they will say that that is even subject to politics. So how are we sure that if we put our money in, our money would not be subjected to certain political influences and certain political decisions? So people have real concerns. And I think as a nation, let's think about it. Let's see how we can change the laws. Because somebody asked me bluntly when we're going around, he said, Dr. Ano, you are a CEO purely because you were appointed politically. You come to us to tell us about these lovely ideas. What if by tomorrow the president says, Mr. Ano, take a back seat? What happens to all these ideas? And I'm like, yes, the president is only carrying out his duties as enshrined in the law. The law says he must appoint. If Ghanaians want the law to change, it has to go through the process, through parliament, get the laws to change, to say that maybe henceforth the CEO is appointed by ABCD. The president will respect that law. But if we Ghanaians make the law this way, then that's the way it should be. But let's debate it. Let's put in measures to depoliticize. I agree with it. If the funding should not go into the consolidated fund before it's moved out of the consolidated fund to Bank of Ghana and all those bottlenecks, let us play open cards so that if the levy, the National Health Insurance levy, 2.5% at the end of March is 15 million. Let everybody know it's 15 million. It's set in a levy account, not having to reconcile books and mathematics to see how much it says before it comes out of the consolidated fund. So these are rare concerns. You
say you're concerned about politicization, but some say you yourself, under your leadership, the politicization is being perpetuated. And they cite the examples of Stella Madonu, who was in charge of NHIA's communication, and he's been sacked. There is Anthony Gengong, who was in charge of provider payments. He is gone. There is Dinah Henny, who was in charge of private health insurance. She's gone. Well, and there are many others.
Yes, yes, yes. I must say that a number of the names that you have mentioned, there are some appointments in the NHIA which are presidential appointments. And for that nature, if you look at the terms and the conditions of the appointment, you will see that either party gives either person 3 months in terms of termination. Okay. And these are presidential appointments. Some of the things you've talked about, some of them are in court, so I wouldn't want to debate them here. Some of the citizens or the members who had to leave the organization have taken the case to court. We're waiting to see how the judiciary will also deal with it. Okay.
Who are those?
All in all,
who are those?
Well, Dinah's one is in court, for instance. Yeah, it's in court. So all in all, I think let us speak to the issues. If all of us are interested in depoliticizing, all the parties, let us speak with that voice. Let us look at the law. Areas which lend itself to politicization, let's look at it and take it out and change the laws.
In addition to the politicization, what would you say is the biggest threat to the NHIS?
The biggest threat, I believe, are the two foundational pillars. All the four goes hand in hand. It goes hand in hand because once you sort out the management and processing of the claims electronically, if you don't have the funding, you'll be in trouble. Because electronically management means that within a week, you know how much you have to pay. The service provider is expecting his money. You have to pay by month.
What is your solution to the funding problems?
The funding problem, will put out about 8 or 9, 10 suggestions out there. Fundamentally, in terms of volume or quantum of money, we're talking probably about 4. The first and the big one is we approach government to increase the VAT component that comes to us. Increase the 2.5% that comes to us to 3.5 or maybe 4%.
What is government's response to that?
Well, they are deliberating upon it. We believe we'll get a good response.
But this is a government that has said that it was going to clear nuisance taxes. It will not impose new taxes. But increasing the NHIS levy is asking the people to pay more for goods and services.
Well, we are actually putting on the table that they take out of what they have. They take from what they have. You know, what they have, they're giving us 2.5%.
Could they have 12.5%?
Yeah, so give us more and then you take less. But, of course, they have to juggle it in terms of the economics of what they have to do in terms of other statutory payments. So that is the big one. We're waiting for government to deliberate and tell us how they will handle that. The second big one is this 1%, 2% that we said that is being in the media, is being debated, various point of view. We have said that is not a tax. I mean, we have Ghanaians who contribute money for even their funerals. They contribute monthly, put money aside for their funerals. We are saying put your money monthly aside for your own health. And for that matter, if you're able to put 5 cedis a month aside, maybe your employer will also add another 5 cedis or 10 cedis for your own health. It's not tax which is going to government.
How is that
as
going
part
to
of government
work?
budget.
How is that intended to work?
It's supposed to come into the levy account completely without going through any government tax or any government consolidated fund or anything of the sort.
Is that for all workers or public sector workers? For
all workers. Those in the formal sector, we've got about 1.2 million there. The informal sector are the biggest. They are almost about 60–70% of the workforce, and we expect them also to contribute their share.
How do you expect to take money from the informal sector? Because they are not structured.
They are not structured, but we'll have to put down the structure to be able to attract them and approach them. And we believe it's going to be easy as soon as we finalize the Ghana card issuance. It becomes easy to identify people. It becomes easy to follow people's income.
The government can't even tax these people. How is the government going to collect any levy from them for purposes of funding the NHIS?
I believe, as I'm saying, once we get onto the Ghana card road, some of these things will become very easy. It becomes very easy. It becomes very, very easy. Believe you me. Believe you me. And of course, once we get the authority that people should contribute towards their health, we will also put in a machinery to do it. Well, the fact that the revenue people are probably not able to succeed doesn't mean that the authority
because the Ghana Revenue Authority is struggling to take tax, especially from the informal sector. There is an admission that that's a large sector,
yes,
but the GRA is struggling to tax them. How is the NHIS? GRA is actually better organized in terms of collection of tax. It has better experience than NHIS.
I've got no doubt in my mind that we'll do better than the number of workers who are now registered with the Senate, which are the target group we are dealing with now. I believe we'll be able to go bigger than that. And again, we strongly believe that our mobile money transfers, our mobile renewal is all tagged more or less to the Ghana card. The trials and everything going across Omo is tagged to the Ghana card. And we believe that it will be much more easier to approach people, to contact people, to know the whereabouts of people using the national identification. And that is what we are all targeting.
Controversially, you've proposed a certain levy on alcohol and tobacco.
Yes.
How is that going to work?
Yes. It's one of the proposals on the ground. But being a middle-income country, we've looked at the figures. The health tax, as we have put it out there on alcohol, sugar, and then tobacco, comes to probably about around 10 million per year. It's not too big. It's not too big. But again, we'll put it on the government desk to look at it. It has a health promotion also aspect or component to it. Once that is done, I think it will come through the various areas where these
Why do you want to put a levy on sugar, for example?
Sugar has become one of the very notorious components of diet worldwide now. There's no health forum where we discuss, where people don't bring up the effect of sugar on obesity and its subsequent effect on diabetes. Diabetes is running amok. So many countries, the incidence of diabetes is rising, the incidence of hypertension is rising, and certainly the increased use of sugar and sugar-related products have a hand in this. And most countries are introducing tax. South Africa started at the beginning of April, and so many other countries have also adopted it, and it's spreading. A lot of countries wouldn't have a choice but to try and use it as a public education and at the same time financially dissuade people from taking in too much.
Do we have an expectation as to this is how much we expect, and when we get the money, this is what we'll do with it?
Oh yes, we want to, as I said, move in terms of per capita from $30 per capita to about $100 per capita. If we get an extra 1% of the VAT, it brings in a revenue of about 700 million. If we get 1% of workers and 1% employee inflow, that brings it probably about 600 million. So we have a reasonable idea about what to expect and gradually how we approach this $100 per capita per year.
Talking about money, there are those who argue that there's a certain level of profligacy in the management of the authority. And they cite, for example, that when you came into office, there were Land Cruisers available for use. These Land Cruisers were registered in 2014. 3 of them, you've packed them, and you've gone to buy new Land Cruisers.
Well, incidentally, these Land Cruisers had been ordered, gone through the procurement process, and everything dealt with already in 2016. But we held back because we didn't have funding to pay it until the contractual agreement in terms of the leeway that they had, that beyond that, they were going to increase the price.
Who ordered these vehicles?
The previous government had ordered that already in 2016.
Really?
Oh, yes.
And there's
We've not gone
evidence to
through,
that.
we haven't gone through any procurement process for purchase of Land Cruisers or approach anybody for it. These had all been done with and finished, klar. But we had a limit when the price could be held. So when we got to 2018, there was no way we could even have paid it if they had supplied it. They would have waited a whole year for their money. But when we got to 2018, the lead period that they given us had almost finished. And that if we do not pick it, then the price was going to increase dramatically. And that's why we thought, discussed with the board and said, okay, maybe discuss, because a caveat had even been put that this car should not be ordered anymore. So we had to discuss with even power side.
Yeah, because the president said that people should not buy new cars.
So we had to even discuss with them and say that, well, this is an old price. We've held on, but it's all been done. The procurement process, contract, everything has been done. Toyota has won the bid already. So it was all done before we came into office.
Wow. But you have taken delivery of the vehicles?
Yes, we took delivery this year because of the time constraints that they were given.
So the 3 old ones, what's happening to them?
We still even need more, not necessarily Land Cruisers, but 4x4 in terms of our trekking and activities and all that. Yeah, it's all being used. It's in the pool and it's being used as and when we need them.
Again, in terms of staff management, there are suggestions that you have concentrated too much power in your hands and you have left your 3 deputies virtually with no specific task to deal with.
It's interesting that people make this comment. Sometimes I wonder where the comment is coming from. If you work there for even a week, you know how intricate the whole work is. One person cannot do it alone, and you're dependent on all the arms. Some of the areas you don't even understand. You got no clue what's happening in finance and Omni and the way they do their things. You go to operations, you have no clue how the claim processing goes on and everything. You go to HR admin, you have very little clue on what goes on in their procurement processes. So it's impossible for one man to run the show. Virtually impossible. I don't know where this comment comes from. So it's such that you can't even go without talking daily. And not daily even once. Continuous
you
talking
may talk,
and continuous.
But if you don't give them, if they work at your behest, they don't have any laid down rules to play because you are concentrated all the power.
You don't have the knowledge to deal with it. You don't have the HR knowledge. You don't have the finance knowledge. You don't have the operations knowledge. So you depend on them. I am here at the behest of CAF. Without them, I wouldn't even know your number. That's how the system operates. So when people say that, they don't really know practically what is going on there. It's impossible to work alone.
Have you done politically motivated or discipline-related transfers?
Related transfers? Sorry, I didn't get that.
I said, have you done politically motivated transfers or discipline-related transfers?
Yes, we have. We have done a couple in terms of discipline-related transfers. And there is always this suspicion out there that this is probably not going right or that is probably not going right. Sometimes administratively, it helps to shift staff around. And when you shift staff around, certain things sometimes come up. Okay, so that in terms of administrative strategy, we'll do it once a while. We do that once a while, yes.
In terms of politically motivated?
In terms of politically motivated, I wouldn't say purely politically motivated. It might be that somebody feels he's been put there because of ABCD, so she could, or he or she could do as he please. Okay, and then when you find out that what that person is doing probably is not in the best interest of the authority, instead of trying to investigate, find a reason to discipline and what have you, sometimes just a mere shift alone, that's the trick.
Really? So many of the people who have been transferred has not been on the basis of political considerations?
Usually a reason why. Usually a reason why. A suspicion of something which is going on. There's always a reason why.
When people are transferred, how long before their transfer grants are paid?
Well, I must say that is one of the problems, just like a lot of the outstanding bills we have. There's always been complaint that, again, we spend too much on administrative costs, spend too much on ourselves as staff. And it's one of the areas where my predecessors have always held back. And of course, when I came back, considering the financial situation of the organization, I haven't really been in a hurry to repay all the previous ones and the subsequent ones. And so these are some of the areas that we're sitting on. And it didn't start only with the administration.
There are claims that you are selective and discriminatory in the way you pay transfer grants. Those you like and those who are MPP aligned, you quickly pay. Those who are perceived to be NDC aligned, they are left to go hang.
Can I, whoever says that, can I put that person on the carpet and give me one person, just one, no more than one person whose transfer grant has been paid? I came to meet transfer grants dating back 2012, 2014, 2016, unpaid because of financial constraints. We have not paid even one. I will need one example.
So not you haven't paid any transfer grants at all?
Not even one. I will just need one example to shame me. I've not paid even one.
Why?
Because of the financial constraints. And that is what I came to meet. If I have to pay, like you put it, I can't leave 2014, 2012, 2011 transfer grant, which is not paid, and pay 2018 or 2017. They will again accuse me of being unfair.
But I got the impression that this authority and the scheme are in a better financial position now than ever.
Yes, but not to the point.
Why aren't you paying transfer grants?
Not to the point where some of the things that involves admin cannot be paid for. There are a lot of admin things which, again, we are holding on. We are in a better position, but we are not as sound as we would be when we put our fundamental pillars in place.
And related to that, let's talk about offices. Some of your district offices are really in a very deplorable state. And you just mentioned how much money is being spent on admin. You have built a fabulous office in Accra, but at the district level, some of the institutions are housed in very deplorable buildings.
I agree with you. And it is in that situation because of the tight budget we are dealing with. I mean, when you are given $30 per capita to deliver service, it's cutting it very, very tight. And that is why a lot of these things are hanging in there.
And yet under that $30, you're able to build a nice office in Accra.
Well, that is a once-off. That is a once-off thing which was done in our administration. And I believe it was essential. It was essential because some of the things we do, as we said today, I would say that even the office space we have in Accra is inadequate. It's inadequate. We are going to move more into hospitals, into clinics, put our members there so that they can please service to our members, so that people go to the clinics or hospitals and they are not satisfied with the service they get, or they are told NHIA doesn't cover this or that. They will have quick response to a desk that they can go for answers. But having said that, our main offices or district offices will still be useful. But the head office, I wouldn't say that it was a waste of money that it was done.
Where are we with co-payment?
Co-payment is one of the things that worries Ghanaians most, interacting with them nationwide. And this co-payment came about because of the backlog of payment to service providers. Going around, we sat with a lot of service providers, and they have given us the assurance that for the past 10 months or so, a year now, the way we are getting our payments monthly, everything coming in, if this continues, we'll have no reason to charge even a penny from anybody. And increasingly, a lot of hospitals and facilities are stopping. We had a fantastic presentation from, which hospital was that? In Volta region, Kratchi West. They've dropped their maternal mortality to almost zero. They have dropped their infant mortality. Brilliant work going on there. And they are doing all this within the funding that they get from National Health Insurance Authority. And I asked them, say on authority, in the presence of all this crowd, are you charging co-payment from your people you render service to? They say no. We're doing it from just what you are paying us. So in fact, the reality is a culture which has come about where somebody goes to the lab, they say pay 10 cedis. Somebody goes to an injection, they say pay that. Somebody receives their blood product, they say pay that. But it is really unauthorized. And as we now get our act together and this payment monthly is going on, we are going to rise up against that, especially if the service provision was carried out below the district level. They have no reason to collect any money from anybody. At the tertiary level, granted, some of the services are so expensive that we do not cover all of them. But almost about 98% of the services provided under the district level are covered and should be free of charge.
There is also this problem of when you go to the hospital and you hold the NHIS card, the health care providers are more willing to attend to those who are paying cash first before they attend to those who are holding NHIS card. And that is because the people paying cash, they have their money. The NHIS, they have to submit claims and it will take an odious amount of time before they get their payment. So they treat those holding the cards as second-grade citizens.
I think this is one of the things that we will seek to root out as we send our members closer to the service provider outlook to check these things. But having said that, my interaction with service providers, I have a feel that almost about 85% of the patient load of most service outlets are on NHIA card. So the people who go there to pay them cash probably constitute just about 10% in most cases or less. So it's just a small minority. So they cannot be treating majority of the patients that are their doorsteps, disrespectfully, because that is where their cash cow is. Almost about 85% plus are from NHIA.
But that's actually the answer. That if the people paying cash are so few, but they are the precious ones, so take them first and let the mass of the people who are holding cash and whose money will come later anyway, treat them after you have taken your cash.
Well, but then if you do that and the system changes, where the patient has an option to choose the hospital that they go to, they won't choose your hospital. They won't come to you again. And you lose 80% of your business. That's what it will mean.
Related to co-payment is the practice of, oh, we don't have that drug. Oh, this doesn't cover, this drug is not covered under the NHIS. And the persons who are holding the cards are incapable of determining whether a particular drug is covered or not. So you go there and they just tick, go and buy this one, go and buy that one, go and buy that one. And you have to go and buy.
Yes. These are some of the things, again, that has emanated from a situation where the hospital administrator felt they were not paid frequently enough. They were owed so much money. So they did all sorts of things, the co-payment, issuing prescription to people to go and collect the drugs outside. Sometimes there's a hospital, a pharmacy is put across the road, and then that pharmacy is not accredited with NHIA, so they charge you any price for the medicine. This has all been going on, but we believe it will all come to an end.
When?
We've taken measures. Now, fortunately, towards the close of last year, Parliament removed the VAT on certain medicines. And with that, the Chamber of Pharmacy agreed that they would drop the price of medicine by 30%. So probably from June going, those new prices, which are lower than it has been in the past, will be rolled out. And when that rolled out, if we find prices which are higher than that, we will be forced to take action. And the minister has said it on a number of occasions. They are going to be very strict with that. An enforcement agency will be put in place to monitor those things.
Dr. Arnold, it's been an honor hosting you on Upfront. Dr. Samuel Arnold, the Chief Executive of the National Health Insurance Authority, has been my guest. My name is Malik Abbas-Dawu. You have been watching Upfront. God willing, we will bring you another edition of this show. Until then, keep safe. Bye-bye.